good morning, good evening, good late afternoon, good late night, depending on where you are in the world. Um, as you can tell, I'm broadcasting from another temporary or part-time studio here in South Carolina. I'll be doing that a lot over the next few months, just like a year ago, I did a lot of broadcasts from the temporary studio in Alabama. Today, we're going to take a little bit of a turn. The company's starting to get into providing guidance to other practices on how to do what we do. You know, we can only see so many people ourselves, and one of the things that we're starting to do is take some of the learnings that we got from the Alabama project and some previous work I did in fee for value with physician partners down in Tampa. I worked full time as their chief science officer for several years, teaching their doctors how to diagnose underlying metabolic disease rather than waiting until somebody's diabetes slaps the doctor in the face. How to look at a little bit more of a subtle problem and diagnose it early so the patient is warned, so the patient can do what he or she needs to do to take that risk off the table before the damage is done. So now we're looking to expand to provide that for other doctors through the channel. One of the things we'll be doing over the next few weeks is providing you some access and links to a website that we're building. We have a full university program where, yes, we have a university program for patients as students to learn this stuff from the patient side, but we have a far deeper program which I developed at Physician Partners, and I developed for the Alabama project for other doctors, other providers, to help them understand the technical side of how to prevent disease damage. So we'll be giving you that information over the next few months as we start getting geared up in this space. Today's topic is actually going to be in that space. We're not going to be mixing too much of the content other than to just make you aware of some of the things that you need to be aware of as a patient and some of the things that you can do to refer some of this information to your doctor, your NP. Today, we're going to talk about a disturbing article that was created from research out of Harvard. Basically, what they showed was, here's the situation, and here's why one of the reasons why there's so much of a problem in terms of healthcare in the United States. You know, the United States loves to be confident and even overconfident, full of itself in terms of thinking we've got the greatest healthcare manpower team in the world. Well, you know what? When you look at public health, our lifespan, our actual health parameters, it's dismal. It's one of the worst among the developed or wealthier countries. Why is it so bad? Well, what we're going to cover today clearly shows one of the reasons. One of those reasons is that over half of the healthcare, the primary care, and quote, prevention that's provided to citizens of the United States is provided by doctors that have been hired by hospitals. Here's the problem with hospitals. They serve too many masters and they're addicted to money. So even though doctors will hire primary care doctors, they don't pay them to do primary care. They pay the primary care doctors to do referrals into their specialists. Hospitals really make their money off of specialist procedure fees. So specialists, because they do the procedures, not the primary care docs, tend to be on the hospital board. So you see, again, a major trend where over half of the healthcare, the primary care, the prevention is being delivered by doctors in primary care, hired by hospitals, who are actually being hired to refer patients to get procedures done. And when I talk to primary care doctors that work for hospitals, they acknowledge, oh yeah, RBRVU. What is RBRVU? Resource-based relative value units, which is exactly what this this show, the topic, the article, the research was about today. Even though hospitals say we have quality and we pay our primary care doctors for quality, no, they don't. They pay their primary care doctors for quantity and for referrals for RVUs. So before I get too deep into that, let's talk about some other things. You know, if you've never been on this channel, here's what we do. We help. I started off as an ER doc, and it became. This was, well, I'm old as dirt. I'm 65. So, and I was exceptionally young. I was in my very early 20s when I finished my medical education. So I started off as an ER doc, and it became very clear. You know, that was back in the day when we called them ER. Now we call them ED. ER, emergency room, ED, emergency department. So after seeing countless heart attacks in the mid 60s, strokes in the mid 60s, early 60s, even in the 50s, and every one of these coulda, woulda, should have been prevented, I said, look, you know, it's fun. It's like being on a TV show, being an ER doctor, but that's not what's best for patients. What's best for patients is helping them learn and prevent these problems. So at that point in time, I said, you know, I really, really didn't want to do that. I grew up, a couple of there were two things that I never, ever would have wanted to be. One was a teacher. And every time I think of teacher, I remember the old Charlie Brown cartoons where they don't show the teacher, they just they give you Charlie Brown's and the kids' version of her voice, and it's going, wah, 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 wah. That's what I always thought about teachers too. And I know that's totally inappropriate. But I didn't want to be a teacher. I didn't really disrespect teachers for the most part, but I did not want to be a teacher. The second thing that I did not want to be was a bean counter, an accountant, one of the guys with, you know, green eye shades and a pocket protector, clicking numbers. Neither one of those things appealed to me. Now, why am I going off down that bunny hole? Here's the issue. When I came to that epiphany, that point, when I remember seeing this was a 58-year-old patient in the emergency department with a heart attack. As I started digging deeper, we found it was very clear. He knew it was coming. He came from a family of people having heart attacks in their late 50s. And they just looked at it like, we've got a short lifespan. This is going to happen to us. And I was going, no, really? Does that really have to happen? And the answer was no. And here was part of the problem. I knew that if I was going to start dealing with the root cause of that issue, I was going to have to become a teacher. You know, it's lifestyle. What you do, what a person does on a daily basis, especially 3 times a day, if you eat 3 times a day, what you do in terms of eating is so important to your lifespan and your health. preventing cardiovascular disease. Like I go to school, I get admitted to med school, I go through all of that training in med school, and then I have to turn around and be a teacher and start sounding like "Wah, wah, wah, wah." That hurt to think that that was what I really needed to do. But I made that commitment at that point in time. And I went to a place that clearly I thought was the best. I was surprised that I was able to get in, frankly. It was Johns Hopkins. And it turns out it was the best. People like to say, well, no, maybe Harvard's better. Not in prevention. The Harvard programs, there's some things that Harvard's competitive with Hopkins on in medicine, most not, clearly not in preventive medicine. For example, typical departments at the preventive medicine programs at Hopkins were twice as big and produced more than twice as much research in education. So I was very fortunate to be able to get into Hopkins. Then very fortunate, I loved what I was doing in prevention. I ended up doing very well. I became the head of the program in prevention and ended up running the program, ended up teaching doctors how to do prevention. One of the interesting things, now, what has any of this got to do with being a bean counter? Well, one of the things you'll hear, if you talk to somebody who learned medicine at Hopkins, you'll hear the term denominator medicine. And it's like, wait a minute, denominator is a math term, numerator over denominator. And here's what that means. So your typical doctor goes into an exam room, head down, talking one-on-one with an individual patient. A prevention doc is not looking, yes, we clearly do. We have a foot in two very, very different camps. The first camp is the patient, the numerator, the one-on-one, and actually very few docs in prevention know that space. We had a separate space at Hopkins. In fact, we were the only place that had what we called clinical prevention programs, which were focused on individual one-on-one doctor-patient relationships and the work that I do, for example, with my patient population now. The vast majority of docs were doing what we call denominator medicine. Another way of looking at it is, instead of looking at all the diseases or disease processes in one patient at the time, denominator medicine, preventive medicine, is looking at all of the population in one disease at the time. Flip the ratio, flip the perspective. Now, why is that important? Well, you see that as critical as healthcare is going from fee-for-service, which is extremely wasteful and which we'll talk about again in the meeting today, the major content, the major program for today. Again, as we get into fee-for-value, away from fee-for-service, we're doing that same flip in perspective. Think about it, when I learned some things about work cells and work productivity and efficiency, work processes at Toyota. I was at Toyota for a decade, senior management there, and had to learn the same senior management and efficiency programs as the rest of senior management. One of the things I learned there that just stuck with me was different types of work cells and efficiencies in terms of assembly lines. They had assembly lines. Doctors do not function in an assembly line for the most part. They function in what work analysts, efficiency experts would call artisan or a skilled trades type of program. It's a work cell. It's one individual. And here's the best way to understand how a typical doctor works today. And we'll talk about what's wrong with that in just a few minutes in terms of fee for service versus fee for value. So fee for service, again, is paying a doctor to do stuff, whether it makes any difference or not. Fee for value is paying doctors to impact the disease levels in their population, whether these patients are coming in to see them or not. So again, you go back to that Toyota artisan work cell model. Think about it. Think about the old-fashioned blacksmith. The blacksmith is under the mighty chestnut tree, as the poem goes. He's got his bellows. He's got his anvil and workstation, his fire set up. But then he's just got junk set up around him. Some nails to do in between time, a broken latch from Johnny down the street, some horseshoes that need to be repaired, some kitchen utensils from Sue's house at the other end of the street. So he's got all this work, and everything is piled up in inventory in Toyota efficiency speak. You got all this inventory sitting around the machine. The machine is the artisan, the blacksmith. Again, what has this got to do with modern doctors versus the changes that are going on? Bear with me. So the artisan, the blacksmith, basically just picks up something and starts working on it, picks up something else and starts working on it. And meanwhile, he might not notice that the town water pump handle is broken behind him and nobody's telling him. Meanwhile, the whole town's going without water and he's working on nails and horseshoes. Exactly what goes on in your typical doctor's office. The doctor only looks at what's in front of him or her. The doctor's not scanning the horizon, is not organizing his work product, is not setting up an efficiency process. Artisan versus assembly line, fee for service versus fee for value. So when we get into a fee for value type of project, and that's what Medicare is transitioning into, whether the doctor's going into Medicare Advantage or whether you as a patient think you're going into Medicare Advantage or not, Medicare is pushing you into fee for value. And let me give you an example of how that's happening. You know, you start hearing it 20, 30 years ago, Medicare's going to go bankrupt. Medicare's going to go bankrupt. So Medicare has had, excuse me, I'm almost over this now. Medicare has had continued decline in their fee-for-service activities because it's a waste of their money and a waste of patient health. Because every time you do a procedure on a patient, you risk hurting that patient. And in the environment that we have today, the vast majority of procedures are not helping, they're only hurting. As in the 90% of stents. I mean, those of you who watch this channel know that that's the case. 90% of stents don't help patients. Well, sticking a stent in somebody's artery of their heart does. It's now minimal risk because so many have been done, but it's obviously risk compared to not doing that. The biggest risk, I will say, is the refocus on plumbing and allowing the patient to forget about lifestyle. So let's get back to the blacksmith under the mighty chestnut tree. So that blacksmith has done the town a disservice because they've been waiting for 2 days to get water, and he's sitting there working on nails and horseshoes. That is analogous to what's going on in medicine today. Medicare has noticed that in terms of what's going on in medicine today, and they are reconfiguring what they're doing. They're paying less and less. In fact, Medicare pays like 30% less for your typical fee-for-service activity than they paid even 20, 30 years ago. So you'll hear doctors complain, oh, I'm not taking Medicare anymore. You hear it all the time. And Medicare's gotten cheap, Medicare's no good, et cetera, et cetera, et cetera. Well, meanwhile, Medicare has continued to pay better and better if you do what's called, if you do fee for value. And most fee for value has come out of Medicare Advantage. It's gotten this bad rep in terms of, oh, Medicare Advantage is for poor people. Not so much anymore. In fact, I'm on Medicare Advantage. And it's not just an issue of he that lives by the sword shall die by the sword. I'm on a very good Medicare Advantage program now. And again, pardon that bunny hole, but some of that has to do with travel. Most Medicare Advantage programs in the past were difficult for people like me who traveled from state to state, South Carolina, Alabama, Kentucky. Not so much anymore. They actually currently now have really good Medicare PPO plans, which are good for people like me that are traveling a lot. Let me go back to describing the old smithy under the tree. So the old smithy is like the doctor. He's done the town a disservice while he was doing a very good job. In his mind, the smithy was really good. He made the best nails, the best horseshoes, and actually he could do the best repairs on kitchen utensils and the town water pump. Any smith he knew. So he thought he was really good. Unfortunately, his work was just misdirected. It was at random. It was whoever happened to get in front of his face next. And that is exactly what goes on with fee-for-service medicine right now. And guess what? Guess who gets in front of the doctor's face right now more than anybody else? It's the hospitals. And the hospitals will say, oh, no, we do fee for value. We have set up programs with many fee for value payers. We have it in our reimbursement for our doctors. No, they don't. What they have is 90% you refer patients to us to do stents, et cetera, and then less than 10% associated with actually impacting the care, the quality of the disease management, disease prevention in their population. So again, maybe I'm going on a little bit about that. I hope. Well, we've got a healthy attendeeship today. So yes, evidently there are folks out there who, even if you're a patient, and especially if you're a patient, you ought to know what's going on in healthcare manpower for the doctors that you're looking to see. So I've gone way deep into that introduction. Let's go through some other things in terms of what this channel covers and what you can get from this channel if you've never been here before. We've basically looked at the things that cause disease and disability. For the most part, by far the biggest issue in the world today is not COVID. It's not infectious diseases. It's a very simple problem. It's called insulin resistance, prediabetes, diabetes. If your doctor has ever said, you've got a little touch of sugar, you should be afraid. Be very afraid. Because you're getting the process, which in many cases, most cases is actually labeled as, quote, normal aging, end quote, but it's not normal aging. We do tend to get increasing insulin resistance with aging. That is the number one cause of it, aging. But genetics are very important. And by far, the biggest thing that we can do in terms of changing this is managing our weight. But there are dozens of other tools. We have now got we've got the best medications that we've ever had. In the past, we had insulin, which is just, you don't want to have to take insulin. And in fact, at this point in time, the majority of the people that used to take insulin don't have to take it anymore. If you're taking insulin, you need to come see us and let us see if you really need to be. But again, that's diabetes, prediabetes. Why have I not mentioned cholesterol? Well, one of the reasons I haven't mentioned cholesterol is the reality is cholesterol is more of a biomarker, a bioindicator than the cause of the problem. Not going to get deep into that, but we do cover a lot of that in terms of this channel. This topic last week, red yeast rice, safe alternative to statins. Supplements are such a big deal in our population. I've had a couple of my patients say to me, I'm glad you covered that about red yeast rice. That was me, and I was doing some dangerous stuff. I'm glad you made us aware. Another thing we cover is lab normal. You know, as an epidemiologist trained at Hopkins, one of the things that I see is that so much research is misquoted, even by the labs. Clearly, doctors, nurse practitioners, the providers today have not had epidemiology training. They don't know how to interpret a lab. And that helps you get to a place where, yeah, a little bit of a different perspective on what a lab normal means. You know, labs basically label normals as 2 standard deviations. Well, 2 standard deviations when in a population like 60 years and older, at least 2/3 have suboptimal insulin resistance or insulin sensitivity. If you're taking 2 standard deviations from a population that's already 2/3 in disease, then you're labeling a huge portion of that population as, quote, healthy, just because they're in 2 standard deviations. That is the problem, and that's part of what we talked about in that topic. Control diabetes, you know, again, if you haven't guessed, we talk a lot about diabetes and prediabetes. And in fact, one of the key reasons is 80% of problems that are, quote, normal aging, including heart attack, stroke, dementia, blindness, erectile dysfunction, and kidney disease, is very much associated with this underlying causality. Now, here's the other problem. Research has very clearly shown this is preventable, and 2/3 of doctors here in the US, where we think we've got the best medical manpower resources in the world, 2/3 of them don't know how to diagnose this problem, let alone how to manage it. So there's some other core concepts as well. Cardiovascular plaque, like Tim Russert. Hey doc, I've got some problems. I know I've got some risks. Can we do a stress test to see if I'm going to have a heart attack? Well, the doctor did. He passed the stress test with flying colors, and he died from a heart attack after passing the stress test. So obviously, a stress test is not a great way to evaluate your issues, your cardiovascular risk. So we get within just about 6 to 8 hours, you can learn the information you need using these courses to protect your health in a way that your doctor, unfortunately, if you live in the United States or the rest of the world, is not likely to understand. You can understand it. If you're not a YouTuber, well, if you are a YouTuber and you value our content, join our channel if you want to help us get that information out to the rest of the world. We continue to do that, and we continue to get feedback. Hey, doc, you saved my life. And that's what makes all this worthwhile. I don't plan to stop doing this. I could go play golf. I could go travel. I could retire. I've retired 3 or 4 times. My last retirement was about 4 hours. I'm enjoying too much what I do. If you're not a YouTuber, but you're a locals gal or guy in Rumble, we have content there. And in fact, we have some unique content on locals that we just don't have anywhere else. We've got a few locals fans and know that they appreciate that. We'll talk about monthly subscriptions later. That has become our most popular way of seeing me as a physician, seeing our medical team. We thought that might go by the wayside if we got geared up with Medicare, and it's really not going to. And again, it's a little bit early to talk about why. We'll talk about that later. I continue to get folks writing in and saying, "Hey, doc, I read your book. You don't give it enough credit. It was really good. And I sent a copy to my doc. Don't expect my doc to take the time to read it, but at least she's got it there." One of the issues, I do use statins, and I expect about 10% of our viewers to drop off when you hear that. There's so many statin haters in the world. Statins are overused and they are clearly abused, but that does not mean there is no place for statins. If you've got cardiovascular plaque, you should consider statins. Only two. There are two by far that are for the most part will cover any of this. There are several versions of them. The cheap and simple one is rosuvastatin, 5 milligrams or less. It's a generic, it's the old-fashioned Crestor. And why do I talk about these statins in the first place? Because they actually decrease. They have what's called a pleiotropic mechanism. What is that? What is pleiotropic? Pleiades, the seven sisters, a whole lot of sisters. Pleo is a prefix meaning many. So here's the point. Statins have always been seen by the standard medical providers as something that helps LDL, bad cholesterol, and therefore that's what it's good for. That's probably not the real issue. It's probably not bad cholesterol. We could go deep into small, dense LDL versus the healthy, large, fluffy ones, but that's for a different time, a different show. The point I wanted to make for this discussion about pitavastatin is there is another mechanism for statins, and that is to decrease cardiovascular inflammation. Most doctors, including cardiologists, and in fact, including most preventionists, don't understand cardiovascular inflammation. You too can understand it within about 2 hours if you get one of our core courses. There's a fellow named Paul Ridker. He had a friend named Gavin Blake. They both are world-class researchers at Brigham and Women's Hospital at Harvard. And they started talking about this secondary mechanism of statins decreasing cardiovascular inflammation long, long ago. And here's what they noticed. They noticed that whether somebody's LDL was low, if they were on a statin, they were less likely to have a heart attack. And they began to develop that theory. And sure enough, the research has been done now over the ensuing 20 years. You don't need a big dose of a statin. You don't need a statin at all, even no matter what your LDL level is, unless you have plaque. Now, again, as you get deeper and deeper into some of the stuff that we talk about, the ADA and especially the American Heart Association. The American Heart Association is finally beginning to get some of this, but still they got it wrong. What they said back in 2018 was, if you have a negative calcium score, you don't need a statin, no matter what your LDL level is. So they're beginning to understand the basic concepts in this area. However, they missed a key point. And those of us who look at things like CIMTs know this. You can have nothing but soft plaque. It's unusual, but it's true. And a lot of people do. And therefore you would think, well, theoretically, what if somebody's just starting to go down this plaque highway, this cardiovascular inflammation highway, and they've got nothing but soft plaque, no hard plaque, therefore no calcification? Could they therefore then have risk, even though they've got zero calcium? And the answer is yes. That research has been done. It's no longer theory. It's no longer just rationale. It's hard data, hard evidence. And I reported on it, maybe 3, even 4 months ago now. So I don't agree with the American Heart Association saying, well, if you've got a negative calcium score, you don't need a statin. Again, they started to make progress, but still they got it wrong. Anyway, that's not unusual for standards committees. If you have an interest in why standards committees get so many things so wrong, get my book. I've got a great chapter on work I've done, work my friends have done with standards committees. And it reminds me of the old joke that I've seen attributed, or the old quote that I've seen attributed to Mark Twain. I don't know who actually came up with it. And the saying is, people that like sausage or law or public policy should not watch them being made. It's the same thing for medical standards. If you like medical standards, you really shouldn't watch it being made. There's too much local political ego and politics that just ruin the process. Anyway, back to this topic. Pitavastatin is, excuse me, I'm getting over a cold. Probably the best long-term, gentlest, easiest statin. And it has now been, there's enough experience to show that it decreases cardiovascular inflammation, fewest side effects, the least impact on insulin resistance. But here's the problem. It's still under patent and it's still extremely expensive. This is a sort of a generic. I'm not going to go into the details of why I say sort of generic, but this is a far less expensive version called Zypitamag. I've had a couple of people take it. They said they had problems with, I think one of them had maybe a potassium problem or some other problem. But for the most part, it's safe and does well, and it's far less expensive than standard Livalo, which most insurance companies will push back on. Now, we get a lot of interest in comments about foods that I cover. I'm watching my carbs. I'm 65. I started having insulin resistance problems in my late 50s. And for the most part, I'm really on more of a keto type diet. I watch this guy, Serious Keto. I watch a couple of different ones. Is Serious Keto the guy that admitted that he was an alcoholic? Anyway, so he suggested these cookies and thought they were great. I got this chocolate chip pecan keto cookie, and it tasted more like a cross between a cookie and a cake. I didn't like it. I couldn't tell if it was because of the consistency, the sort of cardboard dry kind of consistency, or the fact that it mixed pecans with chocolate. When I say pecans, I come from a southern deep South culture, and I think a lot of people expect me to say pecans. Anyway, whatever you call them. I like chocolate chip. I like pecans. I just don't like them mixed. And I didn't like these cookies. I've mentioned chronic care management. We're using that program as well. When you set up a care program and provide care for people coming in from the internet, like we do, you get some people who just have unrealistic expectations. And when you do fee for value, when you do patient direct pay, which we do, you get some unrealistic expectations. We've worked on a way to manage some of those. And the CCM program has really helped. James Santolo, who's a great nurse, has come in and started helping us. Jesus, a great doc, and he's been helping us as well. And Michelle's always been a star in terms of helping patients get what they need from me. So one of the key things that we're looking to do, we're still in the throes of dealing with the Medicare bureaucracy to look at taking Medicare. If you have an interest in working with us, you should check in with Michelle, because we sent out one email and said, look, we're thinking about taking Medicare, accepting that. Do you have an interest? And from that one email, we got 600 people. And here's what happened. 200 people came back and said, yeah, I'd love to. And by the way, I have 2 people that I want to bring with me, friends and family members. So we're getting a way. We haven't sent out any other emails because we knew that the bureaucracy at Medicare was going to take a while. So we didn't want to create frustration. As I mentioned before, we've developed a website. We've developed a new YouTube channel. And basically what we're doing is setting up what we call the Doctors Prevention Network. If you're a physician, or if you have a physician or NP or other provider, and they're stuck in the rut of working harder and making less, considering making decisive action to get out of that fee-for-service nightmare and into actually doing something that helps the patients. One last short deck item, and then we'll get to the main topic for today. We saw this article come out recently, and then I told Jesus we need to cover that. We got a lot of people that are interested in our nicotinamide riboside. A lot of folks interested in supplements. And this one's supposed to be a way of getting niacin without the flush. However, there's just this underlines the whole issue about supplements and over-dependence on supplements, and the assumption that all supplements are not regulated, and because they're not regulated, they're obviously safe. Not so fast. Anyhow, I told Jesus about this and told him, we need to get that out there. Got a lot of interest in it. And then, we got so many things in our queue that this was set up for a little bit later. And then I noticed Peter Attia scooped us. He had a show on it. So he's going to go a lot more in depth on his show. If you're interested in this component, you may want to take a look. What are we talking about? NR, nicotinamide riboside. It's a form of vitamin B3, which is niacin. It's got clinical potential in metabolic and age-related disorders. In this research, this was in biosensors and bioelectronics, early access. They used a bioluminescent-based probe. What they found was this. NR supplementation in animals resulted in a significant increase in triple breast cancer and metastases to the brain. So what we assume in terms of safety, we say, these supplements help our cells in terms of their metabolism. Often very true. We assume that's safe. But one thing we forget about is cancer cells are far more metabolically active. They're out of control, in fact, metabolically. That's what a cancer cell is, uncontrolled growth. So a supplement may actually stimulate growth of cancer cells, and that's exactly what they found with NR. There's an important role of powerful nutraceuticals in cancer metabolism, and you really need to know what you're doing rather than just throw supplements at everything. So, Gilbert, if you'll give us the water ball, we'll get to what's actually going on in terms of most of your doctors out there. fee for service versus fee for value. And the hospital's saying, we do fee for value. We pay our doctors based on the value of what they do. They all say it. But take a look at JAMA. I mean, again, JAMA is a really good journal. And the group that did this research was out of Harvard. Not a shabby place in terms of research. And here's what they looked at: physician compensation arrangements and financial performance incentives in U.S. health systems. Public and private payers continue to expand the use of alternative payment systems, aiming to use value-based payment. Hospitals, which hire over half of the primary care doctors in this country, say that we use it. Health systems and their employment of physicians are still growing. Health systems, code word for hospitals. The study question is, do hospitals pay physicians for quality or quantity? In fee-for-service environments, they're rewarded based on quantity, volume of procedures, not quality or patient outcomes. Isn't that a little bit scary? Objectives and methods. In this study, the authors looked to characterize primary care physicians and specialist compensations arrangements among U.S. health hospitals and measure the proportion of total physicians' compensation based on quality versus cost performance. This was a cross-sectional mixed methods analysis. Sorry, temporary studio. This was a cross-sectional mixed methods analysis of in-depth multimodal data, compensation document review, interviews with 40 physician organizations, leaders, and surveys. So what they did was they went to 40 different hospital systems. They interviewed the leaders. They interviewed the doctors. They looked at the compensation documents. They did surveys. And then they analyzed the data from 2019 to September 2020. Here's what they found. Doctors were being paid for referrals and procedures, RBRVU. Remember I said that? Volume-based compensation was the most common base compensation. For primary care docs, 84%, and for specialists, 93%. While quality and cost performance incentives were common, the percentage of compensation based on quality was below 10%. So your local hospital hires your doctors. This happens with over half of the doctors in this country. And they say, we have a quality-based system. And no, it's not. Quality is less than 10%. So you're grist for the mill. Increasing the volume of services was the most commonly cited action for physicians to increase compensation. So the conclusion was, despite receiving value-based reimbursement incentives from payers, so the payers are out there like Medicare and Humana and others that say, we pay for quality. And the hospitals say, yep, that's what we do too. We've got programs set up there. The compensation of these health systems, primary care docs and specialists was dominated by volume-based incentives designed to maximize what? Not patient health, not population health. Hospital systems revenue, hospital revenue. An associated risk is iatrogenic disease. You know, if that weren't bad enough, you got to remember, as I've said already, every time you do a procedure to a patient, like a stent, you got to remember, you know what? We can cause problems like bleeding in the groin where we stuck that giant needle, which that patient would not have had we not done that procedure. That's what iatrogenic problems means. Iatrogenic disease is the result of therapeutic procedures. It's induced in a patient by the treatment of the physician. So let's take another twist and look at another negative outcome on this is a negative outcome on doctors and the providers, not a negative outcome for patients. So if doctors are still hung up in this fee for service mentality, this um, village blacksmith under the old chestnut tree, if they're getting paid 30% less for every nail they make, so what do? Well, they try to figure out how to make nails faster and faster and faster and faster. Does that sort of ring a bell with you and your doctor? 7 minutes, they rush in, pat you on the back. Hey, how's Uncle John? What can let me look for a script I can write for you, because if I write a script, then I can get paid a fee for service. And we really don't want to dig deep in terms of metabolism and your understanding of things like prediabetes, insulin resistance, because that takes time and it doesn't really get paid in the fee for service environment. So guess what? It's bad for you, but it's also bad for your doctor. What do you think's causing physician burnout? This is exactly what's causing it. We do have a great medical manpower team, very, very well trained, but unfortunately, once they get out into the quote real world, which is fee for service driven, they have a very difficult time actually doing what they were trained to do. They get on that fee for service treadmill. The authors of this meta-analysis, this was a meta-analysis, so study of multiple studies. They looked for the relationship between burnout and patient safety. This included 21 studies from different countries along the US. High levels of burnout were more common among physicians and nurses associated with high workload, long journeys, ineffective interpersonal relationships, and a relationship between burnout and patient safety actions with a probability of superiority of 66%. I'm not going to go down the technical epidemiological bunny hole of probability of superiority in any of that. You know it. You understand it. If your doc is burnt out, if they're doing too many procedures, if they're not communicating effectively with you, they're likely to do something bad. And that's that's the biggest problem with healthcare in the United States today. That's why, despite having such a great manpower resource team out there, we've abused it. The doctors are doing poorly. And when the doctors are doing poorly, they're hurting you. I'm staying with my mom right now, and she asked me yesterday, what's the topic? And I told her, she said, ooh. I said, what? She said, that's kind of inflammatory, isn't it? And I said, well, sometimes the truth is inflammatory. So there you go. Gilbert, if you could give us the transition, we'll go into Q&A. So let me see what we've got today. Tired Looking for Name gave us another super chat. Thank you so much, Tired. Again, if you'd like to do a super chat for us, that's a great way. If you will show, yeah, there you go. Thank you, Gilbert. You go down to, I think it's under the comments, and you'll see this little super chat button. And that helps us get this information out there. Basically, I pay Gilbert's salary and the rest of our salary with either retirement savings or, more likely, money I make from just caring for patients that come in through the channel. So thank you so much, Tired. Tired's question is omega-3 status blood test worth taking? On a research basis, I think it's got value. Do I use it for my patients? No, I don't think it's got significant value. I do think omega-3s have value. I do recommend taking omega-3s. but I don't recommend that test. Thank you so much, Tired. That's helping us get that information out there. William Brewster did the same thing. Super sticker. Thank you so much, William. We appreciate it. Gilbert, I don't know. Does that little square sticker, does that mean that he's a member or something? And do we have members joining that we wanted to talk about today? Okay, we'll get to that.
No, Doc.
Okay, great. Thank you so much, Gilbert. So Rick Folia, good morning from Atlanta. Good morning, Rick. I saw a comment from you the other day, and I hope we were able to get to it. I'm struggling getting to the comments because we got so much going on. Melissa, I got my CIMT results from Cardio Risk. Not good. My arterial age is greater than 80, but I'm 66. No wonder I had an MI. Yeah, I don't get too wrapped up in arterial age because there's significant garbage in, garbage out associated with that. Todd Eldridge at Cardio Risk has done a few videos with us. He's maybe one of the world's best at getting quality specifically around that arterial age component and getting that pushed out all over the country. And that's, one of the major reasons I like to see a CIMT from him. But the biggest reason that I like to see a CIMT from him is that they all include the core piece. And the core piece is this: do you have soft plaque? A, do you have discrete plaque? And B, if you do, is it soft? The vast majority of X-rays or us in your town say they do CIMT, but then they turn around and they don't give me the most important information. And those are the two things. If you decide, I get people that come to me all the time, and I'm always having to say, they didn't tell me anything about what I need. So call them before you get this and ask them, number one, do you tell us whether or not you have soft plaque? And number two, do you tell us whether or not we have discrete plaque? And discrete plaque is very simple. It's an area of plaque greater than 1.3 millimeters. That's it. We're talking about thinness analogous to a human hair. So this is a technical a technical medical test. And what I'd suggest, Melissa, give me a call if you want. Give Michelle a call. If you'll put Michelle's information up, Gilbert, I don't recommend people trying to interpret their own CIMT because it's so easy to misinterpret. Rick Folia, if I take a statin, should I also be taking CoQ10? I do recommend CoQ10 for anybody taking a statin. I did several videos on this topic. The bottom line is, how do you tell if the CoQ10 is actually helping? It's one of those issues where you cannot tell. That's sort of like saying, what is the metabolic health of my mitochondria? It's too subtle, too difficult to measure. Rick Folia at Melissa. The good news is you now have a baseline. Yep. Exactly right. Thank you, Rick. Bambi Grage, good to hear from you, Bambi. D. Dutton, NMN seems to use up a lot of methyl groups and elevates homocysteine. Does nicotinic acid have the same effect? Thanks. Yes, all of the niacin supplements do that. They use up a lot of methyl groups, and I'm impressed. You must have been listening to, oh gosh, I had a senior moment. Somebody was asking me about this fellow yesterday. Rick, is it Rick something? Anyway, bottom line, if you're taking niacin, I suggest you consider a thing called betaine, or trimethylglycine. It's a chemical. You get it. It's not a chemical. It's a supplement. It's a powder you can get in bulk from Amazon, and I put that in my smoothies. And basically, what it does, go back to the name, TMG, trimethylglycine. It has 3 methyl groups for every molecule, and those methyl groups are contributed when you're using, when you're in a need for more methyl groups because you're taking one of the niacin supplements. Subscribe to the YouTube channel, Leo Acapulco. Well, you teach us how to have a better and longer life, so you turned out to be a great teacher. Thank you so much, Leo. I appreciate that. Thanks for all you do. And thank you guys for putting up with my coughing. I had this last January. I think I had COVID at that time. It felt like an ice pick going in my throat. And, we all tend to have this one system that's difficult, that's challenged. And for me, it's my sinuses and my throat. I got that from my mom. Ole Karamak, thoughts on ezetimibe, Zetia? Yes, not a whole lot of thoughts because I don't use it. And part of the problem is it's focused on LDL. That is it. Focused on LDL. So I'm not really that focused on LDL. I'm focused on cardiovascular inflammation. I'm focused on insulin resistance. And just like anything else, supplements, procedures, and especially prescription drugs, Zetia has its risks. So it's like you got significant known risks, and I'm a little bit iffy on the benefit. William Brewster, I had a CIMT done. My early event risk is 3.6, plaque burden 5.5, both high, left. Let me just say this. That sounds like a cardio risk report. And what I would recommend for most people, you may not believe it, I recommend that you really don't focus too much on arterial age. And clearly that second section that has all these early event risk, plaque burden, all of that, if it's high, yeah, I get it. I understand. And the reality is for most of those, the significance is really, yep, I should take a low-dose statin. I should take a baby aspirin. That's it. Don't get all wrapped up in, oh my gosh, I'm going to die. If I've had to have this conversation once, I've had it 1,000 times. Talking people down off of a ledge, getting ready to jump because I'm going to die anyway. Let me just get it over with. No, you're not. Don't overestimate the risk associated with these things. It's true, it's evidence-based, but it's not practical in terms of day-to-day patient health management. Okay, anyhow, I'll go down that digression. Left carotid, okay. Right carotid, 1.9 heterogeneous and 1 carotid 3.6 heterogeneous. I have cardiology appointment in a week. Well, good luck on whatever the cardiologist is going to say about that. What's the next best test and procedure? Probably not a test or a procedure. If you haven't had an insulin survey, that's what you should have started with. Procedure? The cardiologist is going to have 1 million of them. They're going to want to take you to the cath lab. That's the last thing you ought to do. So, William, stop, think, and don't go to the cath lab. Get an insulin survey, or at least an OGTT, because this is metabolic. It's not structural. Melissa, what are your thoughts on biologics? Well, there's a lot of biologics out there. Which ones are you talking about? I have terrible osteo and rheumatoid. Oh, okay. But since I can't take ibuprofen anymore, and rheumatologist has recommended biologics. The biologics for the inflammatory arthritides like rheumatoids are really, really effective. They're dangerous. It's high risk, high impact. I'm hesitant to take because of side effects. I clearly would end up taking some of those. Good question. Good luck, Melissa. I have a terrible pain from arthritis. Tylenol doesn't help. Yeah, I would I'd have to know a lot more about your specific case, but the bottom line is, yes, I'm a big fan of biologics for the inflammatory diseases. Sensitivity for we stuck with Medicare Advantage plans, especially to get affordable RX prescription coverage. Could there be a PrevMed offering we could pay for out of pocket? Maybe with most tests covered by Medicare Advantage. Well, there are Medicare. Will you show Michelle's number again? Sensitivity. I'm mystified by your question. I don't know if your question is indicating that you're not aware of the majority of what we've been doing for years. We've been providing non-Medicare direct pay coverage options out of pocket for what? Within this program for what? 8 years? So call 859-721-1414. That's the number that's right up there. It is interesting and it's true. A lot of people just don't know that we provide care, and we do. I'm just one person, and I'm out doing a whole lot of other stuff, teaching doctors mostly, but I still do this for patients. And I've got docs that I'm training to do that. So Ricky the Gun 1, how do you determine fatty liver? Well, they have a little, ultrasound test, which is sort of like a thump. They have some tests for the liver function tests. What causes it? How do we cure it? That's really the issue, Ricky the Gun 1. Fatty liver is just another, they have discovered, it's been around forever. It's one of these things that they were not aware of. They've just now discovered it. It's associated with insulin resistance. It's caused by insulin resistance. You have too much carbs and you can't really metabolize those carbs well. And what happens is your body starts to turn, your liver starts to turn carbs into fat within the liver. That's what's going on. So how do we cure it? Same way you cure any other insulin resistance. You take that risk right off the table. And in fact, risk, a lot of people say, well, how much risk is there? Actually, minimal compared to heart attack and stroke, the other issues. So I rarely actually talk about fatty liver. But there is risk. And in fact, fatty liver has taken over from alcoholic cirrhosis as being the number one cause of problems, cause of death even for people with liver problems. So if it's caused by insulin resistance, how do you cure it? Taking the insulin resistance off of the table. Insulin resistance means that carbs are poison to you, and you just basically stop eating so much poison. The poison is in the dose. You can eat carbs, just don't eat very many of them. Sensitivity. Oh gosh, you know what? Whoa. I didn't expect to get so much viewership, and so, you cover something like some things are boring to most people, like healthcare manpower. It's not boring to me because it's how I get done what I do in terms of helping public health. But anyhow, the point is, I didn't expect to get so much interest today and so many comments. I can warn you already, we are not going to get to all of the questions. I've just got a few more minutes and I'll cover what I can. If we use Medicare Advantage and travel, are we better off with the PPO, HMO, POS? I don't understand the differences. Yeah, you got to look at each specific one. There are some HMO, POS point of services which work, but for the most part, it's the national PPOs that really make a difference in that space. There are just too many Medicare Advantage plans out there to just make an overall broad statement like that. Rick, hit the like button. Thank you so much, Rick. And we've got a member here. We are Quantum. new member. Thank you so much. We are Quantum. Gilbert, I don't know if you were able to see that or not. Were you?
No, doc.
Okay. Are lifeline screenings the same as a CIMT? That's a great question. In fact, we've had several lifeline screening CIMT techs graduate into some of the programs with cardio risk. No, they're not. Sort of yes, sort of no. It's kind of complicated. The bottom line is it's the same technical issue, same technical process, the same quote interpretation. But the problem is most of those technicians will tell you, oh, no, it's not the same at all. And here's why. They call them a cattle car kind of thing. And it is true. You got to be able to take your time to do a proper CIMT, and you're not able to on lifeline screening. So great question. Thank you so much for asking. Thank you again, Tired, for the super chat, and William Brewster as well. Most lifelines don't do just Doppler. Most of them do an actual CIMT, or at least as of 3 years ago, unless they've changed. Vape King, never on insulin, just went metformin. But with walking and keto, my diabetes is currently gone. Well, it's like Jason Fung says, you can cure diabetes. Yes and no. Some people have so much diabetes, so much body fat, and so much responsiveness to that body fat that when they get rid of that body fat, they actually do get rid of their diabetes. The vast majority of us, more of it's caused by aging. When you do decrease the body fat that you have, every 10 pounds will show a significant decrease in your diabetes. But it's not really curing it, because if you go back and add that fat back, you get the same amount of diabetes that you had before. Oh, Michael Sanders. Hi, Mike in Arizona, able to exercise again. Thank you for all you do. Thank you so much, Mike. Good to hear from you, and glad to hear you're exercising. Melissa, surprised that since taking Crestor, my thyroid has improved. My Synthroid dosage has been lowered now since taking Crestor. That's a little bit of a surprise to me, because I haven't seen that either. Brendan Lenane, good to hear from you, Brendan. 6 months on carnivore diet. Just got my lipids. My GP wants to double my daily Crestor. Total cholesterol 238, HDL 81. That's a great number. Congratulations. LDL 143. Triglyceride over HDL is 0.95. It's less than 1. So, Brendan, you got a little bit of, you wouldn't fit the technical definition for a lean mass hyperresponder, but with a triglyceride over HDL ratio of less than 1, you don't have significant risk. Sorry about that, Doc, wanting to increase your, not sure what to think. I'm not seeing stuff there that would say I personally would want to double your Crestor. I have to go, folks. As usual, I really appreciate the interest in the discussions today, especially in something that's not usually so interesting to the typical patient. I will say this. You're a very, very unusually informed group. And it's very, very unfortunate that your typical patient doesn't look at and think about the importance of what's going on, healthcare manpower. Because as we saw today, they continue to want to complain that the doctor doesn't know how to practice medicine, the doctor doesn't care, the doctor's too rushed, the doctor just wants to throw a prescription at them. But they never think about or understand why. And one of the key things about understanding why from the discussion today, you can realize, if I go to a hospital, primary care doctor, I can assume, if I had a real problem, I can go right into the hospital. It's great. It's perfect. And that's what they'll all tell you. What they don't tell you is, if I go to a primary care doc at the hospital, 90% of what he gets paid for, or what she gets paid for, is referrals, not helping the patient. So thank you so much. I appreciate your interest.